I think we will start now. I'm Samir Kapadia, and I have an excellent panel of physicians with us. I see that they are ready in Vancouver. Hi, Junaid. This is Samir. And
that's right, Janar. Yep.
Who are the? Can you please introduce your team? We are all excited here. We are going to start here, and I can also introduce our team here of the panelists. I'm Samir Kapadia, and James Flaherty is with me, also moderating the session. And then we have Dr. Kang, Dr. Lam, Dr. Liu, Dr. Park, Sinji Park, Wojciech, and Dr. Yoon.
Excellent. So it's Rob Boone here from Vancouver. Thank you very much for asking us to join the meeting. We're excited to be showing a TriClip taste today. So I'll just introduce the team. Dr. Julius is one of the fellows with us. Dr. Sanathanan from one of our other interventional cardiologists. Dr. Fadi Zaki is also joining us as one of the fellows. And then we have Dr. Munt on echo, Rob Ree on anesthesia, and our Abbott team is in assistance as well. Do you want to show the case slides?
And also we have until 9:30.
Okay.
So we have hour and 15 minutes.
We may, yeah, that's lots of time. Not sure we're going to need all of that, but we'll take our time going through these.
That's
you jinxed us, Rob.
Yeah, okay.
Okay, so I'm just going to stand close to Fadi, who's our fellow, just because I'm going to be his mic.
Yeah. Today's case is an 82-year-old female with severe tricuspid regurgitation and moderate rheumatic mitral stenosis with NYHA2 class symptoms, despite optimal medical therapy. She does not have a previous history of myocardial infarction or coronary artery bypass. She's also not had any PCI in the past. Besides that, she has a history of atrial fibrillation. She's overweight at 101 kilograms. She has gastroesophageal reflux disease, asthma, and remote lower GI bleeding. Next slide, please. She does not have any notable history of diabetes, hypertension, dyslipidemia, smoking, or any significant family history. She presented to the emergency room with symptoms of right-sided heart failure, which she was managed with diuresis. However, despite the medical management, she remained symptomatic. Next slide, please. She had a coronary angiogram, and as you can see on this slide, she had unremarkable coronary arteries with no significant coronary disease. Her pulmonary aortic pressure was 44 and 18, wedge pressure was 19 millimeters mercury, RV pressure was 33 on 6, and her RA was 19. Next slide, please. This slide shows her transthoracic echocardiogram. She had an ejection fraction of 58%. She had a dilated right ventricle with normal systolic pressure and a TAPC of 20, which is within normal range. She had malcoacting tricuspid valve with massive tricuspid regurgitation and a pulmonary artery systolic pressure of 52 millimeters mercury. She also had rheumatic mitral valve with a valve area of 2 centimeters squared. Next slide, please. She had a TEE, which showed severely dilated right ventricle, normal 3D right ventricular ejection fraction, relatively large anterior and septal leaflet with a small posterior leaflet. Her TR jet arises along the anteroseptal coaptation line. Her anterior leaflet overrides the septal leaflet. Overall, the anatomy and the imaging is adequate for tricuspid edge-to-edge repair. Next slide, please. Here you can see the TE images. Next slide, please. And our initial plan was to insert true clips. Next slide, please.
So, yeah, maybe we'll talk about strategy when we get to the live echo images, but we can skip ahead.
Next slide, please. Okay, so her case was discussed at the heart team rounds, and she was deemed to be a high surgical risk due to age, and she had isolated tricuspid regurgitation. Her valve appears well suited for TIA due to imaging and anatomy. Our strategy today is for general anesthesia, right femoral vein with one pre-closed proglide, and at the end of the case, we'll do a figure of 8. We'll be using a left femoral vein, 7 French sheath. As you can see on the slide, we initially planned for 2 clips, but upon reviewing her transesophageal echo today, we might start with a single clip strategy with an XTW in the center of the jet. Next slide, please. So before we start, I'll just go through some findings in the recently published Trilumina trial. So as you can see from these graphs, the Trilumina trial examined optimal medical therapy as a control arm compared to tricuspid TIA with optimal medical therapy as the intervention arm. The primary endpoint was a composite of all-cause mortality, hospital readmissions, and a KCCW score. And that was found to be favoring the TIA arm. What we see here is on the left, you can see a graph that shows the percentage of patients who underwent TIA and in the control arm who had a significant reduction in tricuspid regurgitation. On the right, we can see that the reduction in tricuspid regurgitation correlated well with an improvement, that is an increase in the KCCW score. Next slide, please. On the left, we have a forest plot that shows that when they did subgroup analysis, looking at all the variables in the patients who were enrolled in the study, there was a consistent trend towards TIA for patients with improved KCCW scores. For this particular plot, they put a cutoff of 15 as an increase in 15 of points as being significant. We also see that the hierarchical composite of death from any cause, or redo valve surgery or valve surgery intervention, hospitalization, or improved KCCW score was statistically significant. That was the primary endpoint. Secondary endpoints only on the arm of the intervention, looking at complications at 30 days. We can see that 98.3% of the intervention arm had no complications at 30 days. So it's a very safe procedure. There was a reduction in KCCW, there was an improvement in KCCW score, and the tricuspid regurgitation was also seen to be significantly lower in the intervention arm. Next slide, please. And finally, these are the current trials that are looking at tricuspid intervention. The Trilumina trial has been completed and the results have been published. The other trials are currently in progress. Thank you.
So I don't know, Rob, if you wanted to go through your strategy, and then while you're working, we can get some thoughts from our expert panel on indications for application therapy.
Maybe we can just ask Echo if they want to review some of the Echo live images from earlier today, and then we can discuss what we thought.
Sure.
Sure. What do you want to show first?
If you can show us the echocardiogram, that would be great, yeah.
I think these are the images right now.
Okay.
Yeah, so this is done just immediately before. Inflow view of the tricuspid valve showing that still severe tricuspid regurgitation. And maybe...
So the question that, is important, that patient has rheumatic heart disease, and what is the mechanism you think of this tricuspid regurgitation? Because the PA pressures were relatively normal, but the mitral valve is narrowed. So, and the leaflet looks slightly thickened, but again, it doesn't look like they are restricted.
No, I think it's a combination mostly of atrial functional, the right atrium's very big, the annulus is big, and there's a little bit of override of the septal leaflet to the anterior leaflet. So I think it's, as it often is in these cases, a combination of those three factors.
Or you don't think that there is any rheumatic involvement of the valve?
We did not. The MPR area of the tricuspid valve was large, and the gradient is under 1, so we don't feel like there's any stenosis.
Correct. And the mitral valve is still severe, or it is moderate, or it is?
It's sort of mildly stenotic without much regurgitation, so thought not to be a target for therapy.
Any questions from the panel?
So I'm Song Ji-Park from Samsung Medical Center. But I saw the right ventricle is a little bit thickened, and the pulmonary artery systolic pressure is 52 millimeter mercury. So I agree with the etiology of the tricuspid regurgitation combined with the pneumatic and is the isolated, or is the atrial fibrillation related mitral tricuspid regurgitation. So do you explain what is the thickness of the right ventricle? So is it related to the left side valve disease, such as mitral stenosis, or is the tricuspid regurgitation is related to the pulmonary hypertension?
Yeah, I think it's a combination of everything you've outlined, but the main driving thing seems to be the annular dilatation.
So I think that we'll move along here, but I think that what I wanted to highlight is that most of the regurgitation is coming from the antral septal coaptation zone. And so the plan is to put one XTW clip in the mid portion of the antral septal coaptation zone and see how much we reduce the TR there, and then we can have a further discussion. So I think we'll just move along if there's no more questions.
So while Rob's working there, Samir, I mean, we've got an expert panel there. You know, I think it's relevant. I mean, this case was reviewed in detail, and we thought that there was merit in treating the tricuspid regurgitation, as highlighted by fatty symptomatic patient despite increasing diuretics. And I'm wondering what your thoughts, and James and the rest of the panel, is on the indications for doing this post-triluminate. I mean, we feel there is a benefit to do this for symptoms, for KCCQ score reduction. I mean, for us, I have to say I was surprised that there wasn't a reduction in hospitalization, because anecdotally we have found that there's been, and maybe it was because the trial was done in the COVID era and patients didn't want to come in. But I'm wondering what your and the panel's thoughts.
Can you also
that.
show us the fluoro? Because, you know, we are not seeing the fluoro here. So maybe just have a panel. So while you're talking, we can at least see what you're doing.
Yeah. So Don, can we just have echo and fluoro on the main image?
Yeah. That
and
is
echo
good.
too.
And echo, yeah. So at least people can see it while we're talking. So yes, I agree with you, and we can ask the panel too. Myself, I'm slightly disappointed. You know, as you know, we participated in the trial, and I'm very excited about the therapy. But at the same time, it is a little bit disappointing that we didn't see heart failure readmission change, or we didn't see any other solid heart endpoint different. Is it because of the effectiveness of the therapy, or patient selection, or the trial follow-up? All these are good questions. The challenge, as you know, of interpreting this kind of data is also completeness of the data, because if you look at the graphs that you showed and shared about all the patients, how much people had TR reduction, TR positive, there are 175, 225 patients instead of 350 patients. So the numbers that we have even in the key figures of the New England Journal are less than all the patients. So this is where I think the follow-up and the completeness of the data will be important. But I agree.
So Samir, can I follow you up on that? I mean, I was quite surprised at the medical arm about the low rate of cardiovascular death at 1 year, 4.7% that Paul was mentioning. I mean, it goes to show medical therapy is pretty good.
Also, the patient selection. Remember that we try to do the patients that are not end stage. And we also, so whether we selected the patients right or wrong is a good question. While you're doing it technically, if people have questions, so this is a very important part of this particular procedure, that they have a tri-clip system, which has the sheath compared to, because in Korea they don't have currently the tri-clip system. So the guiding catheter that they have has two knobs instead of a mitral valve, mitral clip that has only one. Right there, yes. And this is an important part to say that how you align it from the SVC and IVC. Maybe you can highlight that.
Sorry, I'm sorry, I was working away as you were chatting there, but we did exit the guide in the right atrium and then steer down towards the tricuspid valve with a combination of the SL knob.
Don, can we go large on the camera so Rob can just point out?
No, he is alive. He's live. We can see it.
Oh, you can see it? Okay, good.
Yeah, we can see it. Sorry.
And so I think you can see that on the NPR formats there, we're sitting above the tricuspid valve, and we're sort of very central here, and maybe we can clean that up a little bit in terms of our location so that we can choose between the antral septal coaptation zone.
So this is an important thing that, they are doing a live 3D NPR. You see the red plane and the green plane, and can you just point out the bottom right panel? Maybe clean it up a little bit to show that what are the leaflets there.
Do you want to point that out, Brad, if you can?
We're just getting lined up with the system here, but we're going to try to put it in the same orientation that we get the transgastric view. So we'll put the posterior leaflet around 12 o'clock. The septal leaflet will be to the right of the screen as we look at the bottom, and the anterior leaflet to the front and left of the screen.
So there they are adjusting the red plane and the green plane. They'll put it on the clip itself so that you'll be able to see the clip. And they have not yet opened the clip, as you see.
So yeah, we haven't opened the clip, and these NPR images are pretty good, but if we can't see what we need to, we'll go back to the regular 2D formats.
Right. And you have already aligned it fairly well. I see that.
I think that we're headed in the right direction. It looks like we could maybe
but
head
you have,
more, more towards the commissure a little bit.
Right, and you have a slight slant.
Yeah, a slight.
Yeah, so you can potentially.
Some
yeah, that is, and if you
F
go
off.
towards the septum, see if it corrects itself.
So Samir, can I ask you, I mean, obviously, at the clinic, what would be your strategy for the final residual TR that you would aim for? I mean, when I was training not that long ago, there were only 3 grades, and now we've got massive and torrential, and we know that 1 to 2 grades is beneficial. What's your target? And those are the panel that have done this.
We like to keep it less than 2+, so we want to go to the mild TR format. That is the idea, because as you rightly pointed out, we do have transcatheter valve replacement options. So if you are going to not be able to do that, then it's not an ideal situation. So the repair is, if we are not confident that we can get to that level, or we reach that level, and again, it's difficult. It's extremely difficult to judge these things. So these are the challenges that you face and we face together.
So I think you can see that we've got the clip arms open now, sitting above the tricuspid valve. And what's a little hard for me to determine is where we are in terms of the antral septal coaptation zone. I really want to be quite in the middle there, and we may have to go to the transgastric to judge that.
Right.
Yeah.
You could. So just for the audience, what the picture is now gone, so it's fine. We can look at it again. But
we'll see it again in a second.
Right, sure. And the one thing that I like to do also is to look at the LAO projection for the clip to see that whether the septal and anterior, your septal anterior, septal posterior, because many times you can tell if the clip rotates when you are advancing the clip. But again, it's not a fluoroscopic procedure, but can be helpful.
The fluoroscopy definitely helps in terms of orientation. So we like to get set up above the procedure, then we usually take a fluoro store where the clip arms are, and then do a fluoro as we cross and see if everything is moved.
Correct. And this is an important thing also for the audience to know, that when you have a pre-imaging now we put a sheath in the patient and these catheters, so sometimes the imaging is more difficult, especially related to the leaflets, because it is difficult to see the tricuspid valve since you are seeing it through the esophagus and the left atrium, and larger left atrium also bothers it. So these are the.
So I think we can counterclock this just a little bit to see if we get a better.
So can I ask Samir, what would your strategy be for this case? We're showing what we're doing.
Right. So the two things, so I like the enteroseptal as a initial this thing. I was trying to understand in my mind that how the leaflets commissures are and the scallops are. I was not 110% sure that how but it looks like that there is a very large anterior leaflet, large posterior leaflet, and septal leaflet is just one leaflet rather than two, or there are not that many scallops.
Yeah.
So if that is true, then I like this anterior septal location.
I guess for the audience, the important point is the septal is always your anchor leaflet in many ways.
Go back, NPRs.
And the question, yeah.
No, go ahead.
So the one question is that it looks like that you are slightly posteriorly trending. So it may be not true.
Yeah, we push a little bit towards the commissure.
Yeah.
We're still central there.
Yeah, fairly central, but no, I mean the trajectory. When you will advance it, it's possible that it will go a little bit more posteriorly.
Yeah, I have a hard on this orientation to see that. So do we want to go back to the NPRs, or do we want to try the 2D RV inflow outflow views?
I also like the 3D eyes. You guys use the 3D eyes with this, or this is
We
not?
haven't been using 3D ice.
So Dr. Samir, how often do you use the 3D eyes imaging for the triclip?
I know, again, I don't want to say in my opinion. My personal practice is in all patients, because I like the TE plus 3D eyes, because sometimes it's so hard to see what happens. So then we are learning. So maybe if it's extremely good imaging,
Take a bit of flex off there.
then I don't. But otherwise, I have a very low threshold.
Samir, do you think this procedure will go to 3D ice alone?
Alone is alone in my mind it can, if you have a good 3D eyes. It's better than doing.
Well, then you can go conscious sedation and
Yeah.
not have to do TE the whole time.
So Samir, can you educate us a little bit more on that from
I think we're
your
below
experience?
there.
If you're using both the TE and the ice, what components of the ice do you find are more useful, and which
all the way back.
stages?
I cannot tell the field of view is small, so TE is better. For the field of view, larger, like this kind of picture, is not possible. But grasping the leaflet and how much leaflet you have inside and how you are holding it, those kind of things
More
are much
bird's eye
better.
view of the leaflet.
Yeah.
I think in this case, the image is really good, but in our
No, it's-
experience, most of them, the image will be jeopardized. Maybe it is a pre-existing mitral prosthesis, and also intrinsically, TV tricuspid is not very well visualized in TE. So we put in 2D eyes. I don't have 3D, but 2D eyes helps in case we have difficulties judging leaflet insertion, and we also routinely switch to TTE before we fully release.
Sure.
This is pretty good imaging, I agree.
Yeah, the imaging is nice.
I mean, that's one of the key eligibilities for this procedure.
No, we are aware.
Yeah,
Can
I
you
mean,
put some
it's-
color to see if that's where it is leaking? Just to.
Put some color on there.
So see, it is leaking a little further posteriorly
Yeah,
too.
a little more central.
Yeah.
We'll come a bit more central, closer to the valve. I think some counterclock a little bit. Closer to the valve.
And for the technical people, this is again important to know the IVC to tricuspid valve relationship. So this is also very crucial for the trajectory, and that's where this particular
Can we
sheet
go back
helps.
to the transgastric and have a look? So we'll just have a look at transgastric and see how central we are there.
Right. And again, the patience is required, working together with the imaging
Yeah.
people and the interventionalist is very crucial. And there is
Yeah,
no
it's,
rush.
No rush,
No
take
rush.
our time and see how the imaging guys can help us here.
Because this is the most important part, is to have a dedicated imaging team who does this. Nobody's rushing it, take your time. And because in some ways it's a one-way street.
Yeah, I think you want to take your time and get set up properly on the top of the valve so that when you do cross, you put yourself in the best position.
Yeah, these patients are remarkably stable for this procedure, so it's not a...
But sometimes these clips get tangled because as you can see the leaflets, but it's very hard to see the subvalvular apparatus. In tricuspid valve, if you look at the pathology, there's cords everywhere. So once you go inside, sometimes it's hard to come back. In this, you get tangled, you get twisted, and all those things. So although it looks, with the very expert people, it looks simple, it can be very challenging procedure.
Yeah.
And the leaflets are very thin, so they don't tolerate a lot of manipulation.
And that may be a slight difference between the Pascal and the TriClip.
Exactly.
In terms of how it may get stuck and how to get it out unstuck.
I agree. So Pascal has a clear benefit in that terms for the tricuspid valve, that it's easier to take it in and out.
Right there. Yeah, I think so.
It's an important point you made about the stability of the patients. I mean, that came through very nicely in Triluminate about how safe the procedure was.
And we're just going to switch to the NPR formats here to see if we can get a better view of things.
Sure. And again, I agree that the procedure was fairly safe, but again, if you look at the tables for bleeding and tables for renal failure, both of them were higher obviously, but not trivial.
Although the MACE rate was 2.7% at 30 days, which is low for a
Right.
valve procedure.
I agree.
Yeah.
But 2.7% MACE, but if you look at renal failure,
Yeah.
requiring dialysis, I think 2% or so, and then bleeding was, I think, 4% or so. So it is not, of course, not MACE, but
It has to be respected.
yeah, respected, exactly.
Hmm?
Yeah, nice pictures now.
Looking pretty good.
Yep. And if you turn it right, the blue plane like
It's very central. I would like to see on the sort of transgastric view where we are. That's a bit
No,
better.
but this is a good picture. So again, you see that the red plane is where the clip is oriented. So you
Yeah.
see on the top, and the green plane is the anterior posterior location of the clip.
I think it looks
and
pretty
is
good here.
Fairly central, yes.
Yeah.
Maybe you can check the grippers, which one is which.
That's a good idea. So we drop the mark gripper typically. And you can see on the upper right panel, the non-septal leaflet is marked. So that's the anterior leaflet in this case. So I think this all looks good. Maybe I just close up a little bit and cross here.
Yeah.
Agree.
Do you decrease the breathing rate, or you keep it the same?
Nope, so just a tiny bit more counterclock.
1 second. See, I think if you see the red plane in the left bottom, it is not parallel to the clip.
Yeah.
So if you can turn it clockwise, the left bottom one in the blue plane.
Okay, everybody in the room happy with this?
Yeah, but,
Yeah.
yeah, that's better because now we can see the clip arms.
Okay. I'm closed at 60 there. I'm just going to cross slowly. So do you mind storing this, please, Ryan? Okay, that's great. Thank you. Okay, we'll cross slowly here.
So in my track clip is the Takshami, the in-mitral clip by
Okay, so
Commissioner.
we're across
and
there. I'm gonna
OTP
open
is
up.
the best candidate for the clipping. But what is the triclip? Is that is the MPL imaging or is the transgastric view? What is the best imaging plan for the clipping of the triclip?
Right, so the best imaging plane, because unlike the mitral clip that you can go in the long axis view,
Yeah.
here the challenge is that the valve is rotated, so that's why aligning it in a MPR,
Yeah.
usually from the esophagus, is the best way rather than transgastric because you cannot see the trajectory.
Oh, yeah.
So this
Yeah,
is,
we've crossed centrally, haven't we?
yeah.
We have to move more anteriorly towards the commissure. Yeah. I think we can do that safely below.
So you're advancing the entire system?
Just advancing this whole system anteriorly,
Right.
just very slowly.
And very commonly, you have to grasp the leaflet individually
Yeah.
in this situation. So,
Well, try simultaneously because I think that's sometimes yields the best result.
right,
So we're
And it looks
laying
like,
in the right location,
right.
and we'll see if we can grasp. Sometimes the NPR, it's a little bit more
Yes.
difficult. I think the anterior leaflet's on there.
Right.
We'll just see if we can.
So Samir, at this point, you're using a combination of TE and ICE for this phase?
This phase, I would use, to be honest with you, the ice. But again, this you can do as you're doing. You have a good image, so reasonably good.
but you don't see the paddles quite the way you do for a mitral clip.
Correct.
A little harder to tell.
So now they moved it septally. So,
Yeah. I did torque a little bit septally.
Yeah.
I
Right.
still don't think we've got it fully, so I'm just going to go back into the ventricle and torque a little bit more septal.
Again, most commonly, the septal leaflet is slightly higher compared to the lateral. So many times you have to catch the lateral leaf or whatever, the anterior leaflet first, and then go medially, and then lift up the clip to catch the septal leaflet.
So the anterior's on.
You are moving slightly posteriorly, as you see on the
Yeah.
plane, yeah. But it's good, it's not.
That's good if you can keep us on that zoomed in grasping view. That's helpful. Thank you. Okay, so anterior's on.
Yeah.
I feel confident that the anterior's on. You think it's worthwhile moving to the 2D? Yeah. Counterclock, yeah.
So as you can see here, the septum is moving to the LA. So that
Yeah.
also tells you that the right side that things are worse than the left side. I think although you see some smoke in the LA, which is consistent with some MS, but LA pressure is not very
That's just
high.
going a little bit deeper there.
Yeah, there's an aneurysm bowing to the left side.
So now I think we have septal, but I'm not so sure about the anterior leaflet.
Correct, yeah, the anterior is moving freely. So.
We may have, the orientation may be off. We may need to re-look at that.
On your fluoro, is that changed?
No, not dramatically.
Right, so that's a good news, that probably.
Sure, we'll go transgastric.
So sometimes we can see the movements are very dynamic with the device and the heartbeats and respiration. So is there any tips and tricks for ventilation, anything to stabilize?
Yeah, I like the tidal volume to be 350, but a good point, that instead of doing it at 500, normally 550. So for mitral clip as well as for tricuspid clip, I tell them to decrease the tidal volumes. In the past, we used to hold the breath, but holding breath is very dramatic. sometimes, that it moves everything so badly.
Yeah.
And the anesthesiologist doesn't like it.
Doesn't
You
like
forget
it,
to
and
tell
they-
them to resume the breathing. A minute later.
Yeah.
So I've just gone into the ventricle a little bit, and I'm just rotating a little bit counterclockwise and see if that helps a little bit. That's maybe a bit better. I wonder if we should go more anterior. Yeah, I think we'll
Yeah.
just move a little bit more anterior.
And as you can
Okay,
see,
here we go. Grasping view?
yeah,
Quite close to where we discussed.
you have the papillary muscles and the cords there, so when you go in, be careful.
Mm. So I think that we've got septal here, where it's curled. I'll just see if you guys can clean that up a bit. We've made way more anterior.
Yeah, it is fairly anterior now.
So Samir, would you just focus on the
This looks
interior
like-
and try to get that?
It looks like we have both, or we're pretty
Oh, is it?
close here. What do you guys think, Brad?
I don't think you have the anterior.
Still not sure about the interior.
Yeah, interior goes down. Now, there is a cord there, so you have to eliminate it in your mind, that cord motion, so the leaflet is higher, so maybe it is there, because the leaflet was long.
Yeah.
See, that's a cord in
That
the
loo-
car. Yeah, it
You
looks
think that's
good. I
cord?
think it looks good, yeah. Maybe it is good,
It's intermittently in, I think.
yeah. I'm more concerned about the septal too, that it buckles at times.
It's a little
so.
curled.
Yeah, it does seem to be curling over top there. Wonder if it's an opportunity to just reset everything. I think the septal's in.
The septal is-
Yeah, the septal's in now.
Oh. What do you guys think about that?
Yeah, the septal looks like it is in, but I'm questioning the anterior yet. You lowered the gripper of anterior? Not yet.
No, I haven't lowered either yet. I think I'd lower now.
Yeah, lower it now, I think.
Okay, we'll lower these grippers. So I think we see the septal taut there, and it's hard for me to tell about the anterior. Looks like there's something bouncing in there.
I think the anterior is not inside. It looks that
Yeah.
way, but I may be wrong.
Sometimes we look at
Any other
bouncing
suggestion
of
about
the
imaging?
Grippers on X-ray.
Yeah, you can do transgastric.
You can see the anterior gland. That's the goal. Separate it down here.
So as you can see here now, at least
Oh,
you have a
that
long,
looks,
Show us that anterior clip
A
on
little
there.
hint of something looking promising
Yeah.
there.
yeah, maybe, again, going in the transgastric view might be easier to.
This case illustrates how tough it is to see those
Yeah,
leaflets.
and
on
exactly,
the
Yeah.
top.
yeah. And it is, to be honest, this is the norm rather than
the Achilles heel of TriClip.
Yeah, it's the visualization. You're so right. And that's why I said that, many times I like to put the eyes, not so much because I don't trust the TEE, but because whatever extra things you can see is an advantage. That's how I look at it.
Yeah, yes, me too.
Com-
Adding
complementary
devices
is
for
what you're
visual
saying, I
clues for safety margin and assessment.
And as
Maybe
you
just
can,
close to 60 here and think it's out. Yeah, okay, so we're pretty confident that we don't have the anterior leaflet.
correct. I see it moving there. You see on the
Yeah, you can see
left
it coming
side.
on.
See
Yeah.
how it is moving away from the clip, whereas a septal leaflet is inside. So that is consistent with the idea
So the
that,
grippers are up, and we'll just open up a little bit. And I wonder if we can just move.
yeah, you can just move anterior.
Anteriorly there.
If you counterclock the whole guide, usually it goes
Yeah.
anteriorly and clockwise goes to the septum.
It looks like the septal's coming along a little bit.
That's
It's
good.
hard to see in this view as to whether you've got the anterior leaflet sitting over top of the arms.
It is
I wonder if we
hard.
should go back to the mid-esophageal views.
Right.
Sure.
Big boards on the lateral side, I think they're just kind of fitting with the one.
I was
See
just
that?
saying, so maybe just counterclock a tiny little bit.
So we're going to try to position the orientation of the clip to get away from the cords that are sort of more central into that anterior leaflet.
I think that's probably pretty good. Yep. Mid-esophageal views and see if we've got a better sense of leaflets coming over top of the clip arms. You see the big cord there. Looking more promising.
And maybe you can pull back the clip so that it rests on it comfortably rather than coming up from it.
Well, coming atrial there, it seems to be just sliding by a little bit.
Yeah, we have a little difficult thing to see because the gains or the monitors are different, but you must be able to see it better.
Yeah, we can see it better on our screen than what is being
Right.
projected. So
No worries, yeah.
It looks pretty good.
Septal's falling in.
And septal's well in there.
Yeah.
And what do you think about that anterior leaflet, Brad?
Better,
Looks
yeah.
better,
Just get grasp it, yeah.
I think if we just drop these grippers now.
It's intermittently anterior.
Yeah.
We're still not sure about that anterior leaflet.
Okay.
Yeah, the anterior is still moving. At least, again, it's not very super clear here, but
No.
there it looks, a second ago it looked a little promising. No, but I agree.
Oh.
Anterior is questionable. Yeah.
So we'll just wait to see if Echo can. So I don't think the anterior leaflet's in. So we'll brace the grippers.
Yeah, I think maybe,
And I wonder if it's worthwhile coming back
Back.
above and resetting everything.
right, it might be worth it, yeah.
We'll just wait for a second, have a little converse. We have
Yeah,
any
yeah,
ideas?
yeah, talk to it. Yeah.
Yeah, I mean, I guess in some ways that's
Can't hear you.
makes TTVR sometimes attractive when the imaging is so poor that, not in this case, but in
I think
others
you
that
raised it
use
above.
screened.
Yeah.
Some of the technologies.
So there it is looking better, huh? Just a second ago when you can see.
Yeah.
Yeah.
It's like it's playing.
Yeah, it depends on the ventilation cycle. Can you decrease your tidal volumes or
Or
something?
suspend when you grab.
Yeah,
I wonder if it's just looping over top that cord. But it certainly looks like there's some,
It looks intermittently in.
yeah. There,
it looks promising there, yeah. And now if you lift, you go more atrial, maybe you can stabilize.
I think it just slips by. I don't think we consistently have it.
No, and also the clip
think
looks
we're-
slightly rotated on
Yeah,
your.
I think we're better to reset, come above and reset.
Right.
Do you want to try a strategy going for the anterior first?
We could do that. You
mean-
mean down here?
Or reset and try that?
Reset
You've demonstrated you can get the septal consistently.
yeah.
It's the anterior, the one that's slipping off.
So here they
So we
everted.
everted the clip. Come above into the atrium. Close the clip arms so we're in a grasping view. And then we'll reset everything.
So
I think
the challenge is that you have a lateral to septal trajectory. So that may be the reason why you don't catch the anterior leaflet. So
Yep.
you can correct that trajectory if you can. So
We'll take some L off.
L off, yes. And then maybe counterclock it to see.
One thing I wonder is, beside the decrease of tidal volume, the
No, it won't
volume-
worse, yeah. I'm sorry, go ahead.
yeah, volume control is necessary before the triclip procedure also.
With deep breaths, it moves quite a bit, so if you can control it, it's better. But as you see, it takes a long time, so you cannot keep holding the breath. So that's why we decrease the tidal volume.
So sometimes we increase the decrease the tidal volume, compensate by increasing a little bit respiratory.
That's exactly. Yeah.
Instead of previously mitral clip, we hold the breath.
Yeah, you can keep
Yeah,
the
yeah,
doesn't
yeah.
work.
ventilation.
Yeah.
Minute ventilation the same,
Yeah.
and
Yeah.
try to. So that trajectory looks better to me.
Better, yeah. I wonder, sorry? And I wonder if we should check the orientation now in 3D again. I'll just see if I get closer to the valve.
And your imaging plane is also better because I think it is not right behind in the fluoro, behind the clip. So you're watching the valve because before it was right behind the clip. So this is a good place where you will be able to see the valve if you do
Yeah,
the 3D
I
here.
think that's looking pretty better.
Yeah, on
Much
our
better,
screen,
much
the
better.
leaflets are easier to see.
Yeah. Should we just check either the 3D or the transgastric just to make sure?
Here, I think if you do a 3D MPR, okay, you can go transgastric. Yeah. Beautiful.
Yeah, that looks better.
We're going to go to the transgastric view and just
Okay,
check
sure.
the orientation of the arms.
If we could come more central in the valve.
I think there is more coaptation gap there, so I stay there where you are because I think you have an easier chance to catch it.
I think your orientation looks pretty good.
I'm not convinced yet, but maybe they can show it to us. Yeah. Looks okay, I think. Yeah. Is it needs a little counterclock or not? This is the question, but I'm not sure.
I thought it looked pretty good, but
Can you?
I don't know if we can see it a bit better. I'll just try a little bit of counter and see if it cleans it up.
And go closer to the clip, yeah. Closer to the valve, maybe they can see you better. Yeah.
That's better.
That's better, yeah. Now, fluoro a little bit. See if it went up. Because it looks like it went a little bit too anterior on this TE, but maybe not accurate.
I just pulled it a little bit, but we'll see if we pull it a bit more. There we go. You guys happy with that?
Sure.
Yeah. Come more central. Just go a bit more. Okay. I wonder if we should eat more clockwise.
Slightly clockwise.
Yeah. Yeah.
Yeah. One trick I sometimes use is align the fluoro such that the clip is, take the parallax out, so when you are moving, if it moves, you will know. So that if you just make RA or LA or such that the parallax is gone, then you can.
It looks pretty good on fluoro here. It looks
Yeah,
like a
very
straight
good,
rod.
very good.
So should we go back to either an NPR or a 2D mid-esophageal?
You mean you find your fluoral view that shows no parallax?
No parallax.
And stay in that view.
And then I
Yeah.
stay in that so that when
Yeah.
I'm doing mitral clip or
Yeah.
tricuspid clip, if the clip moves, I know that, this is where
Yeah.
I started and
Yeah.
this is how it moves. So.
I think by movement you mean rotation in the clip arms.
Exactly. Rotation is, yeah, exactly. So if it's turning, you would have a, this is just a,
This
it's
looks
just,
pretty good, I think.
yeah, it looks good, yeah. It's
That's
just for
better.
fun.
It's close to 60 here. I think we'll cross here. Store that, Ryan. And crossing.
You really see the leaflets well here.
Yeah, beautiful.
Store. So your suggestion it will go anterior first. I don't think we're playing on a chord there, maybe.
If you made it go a little bit more laterally from the sheath, maybe you can catch the anterior and then come to the, lower the gripper and then come to the end. It's like a independent grasping, maybe necessary.
Yeah, maybe that might be necessary here.
Yeah.
If we have the longer clip than XT, then would it be easier for those case?
Tell me again.
If we
So
have
with
the
an XT, so we
longer-
can avoid the,
Yeah.
there's anterior on.
Yeah, that's,
Oh, was there?
was on. Slipped off. Oh, okay.
Okay.
So I think that it's sitting in there.
Yeah, you
Yeah.
can lower the anterior gripper at
Yeah.
I think we're
Anterior is-
going to lower it.
I think it's falling in.
And that was the dot, I think, wasn't it? Yeah.
Oh, it slipped.
Yeah,
So they
Yeah.
lowered the anterior gripper there,
right. And now you can go septal.
and now I'm going to go and see if I can get septal going a little bit. Oh,
Oh,
it came off.
Fell
You
off on the
came off,
anterior.
yeah.
In the canyon, you think we're too central here?
Yeah,
Should we just
expansive.
look on the
Transga-
3D again, or the transgastric?
So one thing that I know that there's no data or anything, but instead of using the XTW, a regular XT, sometimes is easier for me because it doesn't engage with the chords as much. So even though it sounds counterintuitive, that, TR and all that broad and things. So many times these days I use XT rather than W because this is the only downside of the clasp. Again, in the clasp, you need a smaller clasp because otherwise it does the same thing. That, you go inside and it decides where it's going to go.
Yeah.
So I think it looks pretty good, but we'll push in just a little bit, see if we can get away from that cord. See if we push a little bit more to the, there we go. It looks like we have anterior now, maybe.
Mm-hmm.
I think so.
Should we go back to the mid-esophageal?
I think this just demonstrates there's no such thing as a straightforward tricuspid tear case.
Yeah, that was the attempt.
Yeah, it's very hard to predict what's going to happen when you get in there.
Mm-hmm.
So I do think anterior is sitting in there.
Yeah,
I
Just
think
going to
so.
come up a little bit.
atrially, yes.
Yeah, and you're
Yeah.
not far from septal either.
Yeah.
It's curling a little.
I'm just going to take the anterior, so I'm going to
Correct.
drop the anterior gripper here. Not sure.
Maybe drop the septal too because I see it.
Yeah,
Or
I
you
think
lift it up.
Septal's in now. At least it was.
Drop both of them.
Yeah, I would drop both of them.
They're both down there.
Right.
I'm really not sure about the anterior side, but we'll close up to 60 here.
I thought I saw it in.
It looked good.
I felt good
They
about it.
both look like they're better there.
Yeah.
Yeah.
Yeah, let's just look at transgastric and see if we,
When you
They're
close,
both
Rob,
coming
it looks
outside.
good.
Yeah, it looks
that looks
inside.
better. That looks really good.
You are 60-degree closed on the fluoro?
Yeah. So if you guys are happy that, we can close this.
Yeah, while you are on the transgastric, close it so you see it both coming in.
Yeah.
It looks better. It looks,
So whenever you guys are happy with the view, just let me know and I can close it.
Yes, we can close that.
You guys happy to close?
Yeah, you can
Okay.
close now.
Closing here.
Nice.
Seem to make a difference?
yeah, it is much
think so.
better. Yeah.
Much better.
So we release some tension and you guys can have a look around there and we can make a decision about, I think we'll release this and then we have to decide whether it's going to need another one.
Hmm.
That looks really good.
That looks good, yeah.
You're cinched up tight there.
Yeah, you
We will
have
have
a
to put
leak.
another one in.
You have a leak posteriorly.
Yeah. So I think we should look around transgastric or NPR and just see if we've distorted things.
I agree, and also check the gradient slowly because
Yeah.
unlikely that this is, because it looks big, but there's no flow acceleration going in. But the question is that really this changed the TR or not. This is a good
Yeah.
question, that whether it affected the TR.
It certainly seemed to on the transgastric, but
Yeah, no, it did when you're
Hard
closing
set,
it, right. I am of the opinion that even if it didn't affect the TR, leave it, and then it's
pull
easier
another
to
one next to it.
catch below it. because-
Anchors for the next one.
Yeah.
But
Yeah.
there's still at least severe TR here.
Yeah.
Yeah.
And this is the challenge of this particular procedure, that you don't have a way to go back. So let's say you deploy this and then you say, now I want to put a new one and it's not 100% aligned. What do you do? So you're not putting two at the same time and then releasing it.
So usually sometimes cannot in the middle, then you come to commissure. Theoretically, it will helps. I will check the other whether I can have confidence to grip other places. Otherwise, it creates some distortion.
Exactly.
Actually, make things worse.
Yeah.
Yeah, you're absolutely right. I have in the mitral position, because this is research, in mitral we can do other things. So I have put two clips at the same time to
Yeah,
see.
move it. Yeah, I think we're just going to accept this one and put one next to it. I'll probably run out of time, but
No worries, no worries. We have about 15, 20 minutes, but you will do the XTW?
yes, second XTW.
Okay.
So we're just going to check the lock
Do
here.
you use much XTW in your practice, Samir, or not really?
I do. But I like sometimes for the mitrals and things, I like the XT because I can go closer to each other. And sometimes the XTW opens when you try to release it because there's so much leaflet inside, not for tricuspid, but more for mitral, where there is a lot of leaflet,
Yeah.
it wants to pull.
So we're talking about optimizing the anterior now rather than deploying this.
So can we know what now the TR, the morphology, or is it the same? Is it because of torsion? Is it still an anteroseptal, or is it?
It
I
is
mean,
all
the
the way
next
across.
target is where we put the additional clips in case we want to put.
Yeah, I think the leaflet is inside. The question is that whether it is distorting it, whether it's turned in a way that it is, because I see the anterior leaflet fairly tight.
Yeah. And to me, the TR jet seems more impressive than I would expect with this.
I agree with you. This is what I was questioning, that whether this is affecting the TR or making it same or slightly more distorted and worse.
Yeah.
You have a pressure there, the V wave or something, so sometimes that helps if you are connected with in
Yeah.
your tri-clip sheath. Do you have a hemodynamic?
So I think that what we're going to do is open this
Okay, sure.
and see whether that TR changes, but we're very, very tight on the septal leaflet here.
Mm-hmm.
And I wonder whether we've distorted something. So I'm going to unlock the clip.
See, your probe is very high now compared to where it was. So
Yeah.
TE probe. So I think if you lower it on fluoro, it was.
So whenever you guys are ready, I'll open this up.
Yeah, so you can see a little bit of mobility on that.
See there, it looks good to me. That at least
It does look good.
yeah, the leaflets are good. The question is that whether that's where the TR was and whether
Yeah.
we affected the TR. But I think the insertion is very good.
Yeah, there's lots of leaflet inside the clip here.
Yeah.
So what do people think?
If the clip is stable, it's just a question whether to release it and put a second one.
Yeah, so keep this one and add a second one more centrally.
Residual anterior motion would just be the one.
Just scroll over a little bit more centrally. It's significant.
There's this
Yeah. So we're just looking at the anterior leaflet there, thinking if we could just maybe optimize it, make it a little bit tighter to allow a more firm grasp with a second clip. I don't know, it looks pretty taut there.
It looks taut.
it's in-
The question is that, it is, as you know, it's easier said than done, all these things that we can, because I see
think
the
there's room
cord.
for a second one right there, don't you?
There is a cord,
I
right?
think we leave this and put a second one right next to it.
There is a cord also right next to it where
Yeah.
you want to put a second one. So again, instead of XTW, if you want to use XT, that might be a strategy. Because see, if you go a little bit further, see right there is a cord,
You got to interact with that cord.
right? Because
Yeah. And just go a little bit more centrally with the X-plane.
see right there,
There's a cord there.
big cord. So
Yeah, big secondary cord.
Mm-hmm.
Okay, well, let's release this one. So we're in neutral there. One turn open. Doesn't open. Close. Yeah, the flush is up. Thank you. Okay, do you want to take this off there, Fatty? You know how to unwind that. And then just taste the grippers, or floss the lines. Okay, that's fine. And then just floss the other one. And then just pull out with that one. So it pulls out, yeah. There we go. We'll test the lock again. Neutral. And the blue line is one turn open, doesn't open, back to neutral.
Pin.
Release pin. Okay, do you want to do this part? So 9 turns and then the grippers. Oh, 9 turns here. 1,
Towards you.
yeah. So this
No.
one, and then I'll take it back. Ready?
pull that first, yeah.
Pull the
Yeah.
blue pin.
Pull that, pull all the way back, and pull the gripper line. And there we go.
Clip
Sorry.
is very stable, so that's the good news. Now let's check the TR, because sometimes, there's a lot of tension on
Yeah,
the,
it may be a little better because it was really taut.
We're in.
yeah, the probes.
Can I get the...
Yeah, that's good, yeah, put color. Yeah, a lot of TR still.
It's very similar.
Yeah,
Before we were, yeah.
So go ahead, yeah.
so do you hook up the sheath to the pressure? Because sometimes,
Yeah, we do.
yeah, sometimes that helps to see if the V wave have
Silver line.
changed.
No, one silver line. There you go, now you can pull everything. Okay.
Start to see that one.
So we have a XTW prepared.
Sure, go do it the
What do you guys
XTW.
think of that? I think we go with the XTW.
Sure.
It's ready. It's already open.
Can we
Okay.
check what is the morphology of a TL now? Because sometimes it's changed a little bit on the location.
Yeah.
and Maybe you change your strategy to posterior septal or anything. So can we check? A 3D, for example.
3D maybe MPR, can we do 3D MPR here? Slightly lower probe maybe.
So I still think the majority of it is coming from the anteroseptal So I still think that a second target is anteroseptal. And we were a little bit posteroseptal. But I kind of think on this view, the idea would be almost like 3 o'clock, 6 o'clock. Or sorry,
Yeah.
9 and 3.
Just behind it, but I
Yeah.
don't know that whether you can tell which is anterior and posterior leaflet easily because it's almost bicuspid looking valve. So,
Yeah.
So somewhere there,
I think we put a,
right. Instead of that, just horizontally, slightly
Yep.
counterclockwise.
yeah. Okay, let's bring up the XTW. Yep.
Can you measure the V wave while we are waiting, or?
Yep, I can.
What was it before the case? Do we see it before?
It was 25, I think.
Okay.
It says 25 on the slide, yes.
So that's the V wave now,
We're not seeing it, do you?
roughly the same. Do you have the hemodynamics there? So it's 18.
Okay.
Just in top right corner instead of the fluoro, just for the moment,
Oh, I
hemos.
see. Okay.
Oh, sorry, I can leave it there again for you if you want it. There you go.
You can leave it connected while you put the other clip if you don't need that.
Yeah, sure.
So that way we'll see if at all it changes.
Run a lights on there.
So if you don't have the tricuspid clip and if you want to do with mitral clip, I'm not suggesting this is not a IFU use, is to load the clip clockwise 90 degrees, then you can do almost all manipulations with the mitral clip. So this is what we use for commercial use when we don't have, because even in United States this tri-clip is not approved yet.
So, Dr. Chairman, is the previous you told me is the estimation of residual PR after triclip is only the visualization of the color imaging, but it is not sensitive, it is not exact, and it is not incorrect. So in mitral clip, the time is that we estimated the liver disappearance of the right pulmonary venous liver cell, or is the 3D venous contract area is less than 0.3 square centimeter. The kind of correct parameter of the residual MR. But how about the triclip?
I agree with you. This is a very million-dollar question that when you are assessing the residual TR or TR, only color is obviously not a good idea. Yeah, it's not a good idea. So that's why I'm trying my best to say that maybe measure pressure. So that might be one way. The other method could be that we can look at the V waves in the hepatic vein. You can look at the flow reversal and things like that. So just like you look at the pulmonary vein flow reversal, you look for the flow reversal in the hepatic veins. But this is a questionable thing because it's difficult because it is TR, low pressure chamber.
Yeah, I know.
Yeah, so it is. So now they are flexing the.
Put the L back on, I think.
Yeah.
So when you assess the outcomes, do you think that the clinical improvement is really in parallel with the echo improvement? Because sometimes they improve despite we are not happy with the results in echo. The patients report the improvement in the...
At least in my experience is, if we are honest about how much TR is there, it is consistent. The problem is that not honest is the right word, but if you are able to judge the TR, because sometimes what I say 2+,
Sorry?
it may be 3+ or 4+. So this is the challenge, that people don't feel good is not because we corrected the TR. Sometimes if the RV function is not good, then we struggle.
Although in Triluminate, they were centrally adjudicated, so the more you got reduced, the better they felt.
Correct.
So-
But again, few patients.
Yeah.
So not all
So-
patients.
Close to the aorta there. Issue. we have some more L here?
I mean, a lot of discussion around the trial with Triluminate about the potential placebo effect, but I mean, I think that graph showing the correlation is a little more reassuring, hopefully, in the long term.
Yeah, this is the most important message too. But again, in that curve, the number of patients are not that many. So this is where it bugs me.
I think the 5 year is going to be what makes or break that, because those that weren't treated are going to get worse. You know, hopefully the treated patients hold up. But we know what the natural history of the untreated group. It's going to get worse. And they're going to get sicker, and liver, kidney. So I think long-term is the...
You are not straddled completely, so this is a little bit of a challenge, yeah. So maybe
Trying
if you
to-
put a negative on the guide, you may gain some
I
height.
just put almost a full turn of negative there.
Yeah, and then you can push the thing out because,
Gain some height with the negative.
yeah. Yeah, looks good now.
So we're straddled now.
We still have 15 minutes, so plenty of time to get this...
No, I think we have not 15,
Oh,
right?
5? Oh,
Five.
5,
5
oh.
minutes, 5 minutes. So
Yeah,
we
that's
won't-
okay, take your time.
did jinx-
Don't
I did
rush it,
jinx myself.
please don't
No,
rush it.
don't rush anything.
We had a great
We
demonstration of how, patient
Jinx
we are.
ourselves.
Yeah, and we have to be patient and,
Well, we'll see. I think the next session in this room is 9:40.
9:40?
Well, I mean, I think hopefully you've seen some nice demonstration of some of the considerations with this. I mean, this is the reality of this procedure,
Oh, I think it was tremendous look at what this is really like
TVR believer.
in real life.
I'm with Samir. I like the trick valve, Rishi has convinced me. I don't even need to know any tricuspid anatomy.
No, I won't go that far. I think
Only joking.
No, I think there is value of treating tricuspid regurgitation. So both have positives, so.
I think the challenge more for our, that we struggle with our program is we have plication, TTBR, now cable technologies. Fitting which patient gets what is sometimes not necessarily straightforward.
Well, I think procedural replacement is clearly easier, but it has its own issues. Anticoagulation, durability. So I don't think it's ready to say that we just move in that direction.
And no clear winner, so to speak.
No, it's learning. They are claiming that we will have to go at 9:30, so we are.
So it looks like we're sitting above here. I don't think we're going to get it finished by the time.
No worries.
But I think we're playing in the right location here.
So just to summarize, if you want to summarize and tell us what you think about this procedure and how to use it, that would be great. We have a couple of minutes, and then you can do your rest of the case.
Yeah, so I think that in my mind, repair, if the anatomy is good, the imaging is good, I think repair is a better way to go because I think that it's a bit more predictable in terms of its outcome. In terms of long term, we don't have the anticoagulation, the pacing issues, the durability issues. So I think the technical challenge, the slow procedure that's a bit unpredictable when you're starting in a case like this where you think things are going to go smooth and they take a bit longer. But ultimately, I think patients get a really good outcome. And I guess the other thing is it's safe and done repeatedly all over the world with reasonably good results.
Wonderful. Yeah. Any questions from the panel for the operators and we are of course very thankful for all of you to give
great demonstration.
Great teamwork and demonstration.
Really worked through a lot of the nuances of this procedure.
Yeah. Any questions for the group in Canada?
I'll just make one quick comment. I mean, I think unlike left-sided, issues on the right side, I think there's tremendous potential for percutaneous options because we know that the alternative of surgical is not necessarily straightforward for a lot of patients. And we know that the rate of isolated tricuspid valve surgery is quite small overall, globally, and certainly in North America.
Right.
So-
No, I think just to correct you, everywhere there is an opportunity. So left, right, up, down, nobody wants surgery.
Well, to your point,
Put that in equation.
nobody would be advocating surgery for this woman,
Yeah,
For
no.
anything, yeah.
yeah. But
For
particularly-
bypass to leg surgery to,
Particularly for just a tricuspid valve. That would be a big sell in a patient like this.
Yeah.
no, wonderful. No, I think we had a great time and we are very thankful. We are going to let you finish the case. And thank you
Thank
for
you.
an outstanding presentation.
Well, thanks for inviting us to be part of the conference.
Thank you.
Thank you.